Katrina, did you get a list of
I don't think I've
questions?
ever done an in-service for PACU.
Really? Ever?
So I can walk away if I
Wow.
need to and go start a patient.
Yeah. Nobody sent me questions. I just had little bullet points of
Oh, okay.
little things. Do you want to just chat a little bit about your patient population in
Sure.
general, what we're going to see overall? I know
Sure.
we've been seeing them, but
Yeah, so I've been doing, HPB and general surgery over the years, but I think now we're just doing just the big stuff here. So I mainly do pancreases and livers, and by extrapolation I do stomachs and small intestine also, mostly cancers. And I also do the bad gallbladders that people don't want to do. I get a lot from Jim Cook.
Okay.
Yeah, so, sometimes they're,
He refers,
they're
yeah.
difficult, or they're like completion gallbladders where they like took half of it and I go take the other half. But mainly the big bad cancers of the pancreas and of the liver, and most of my big cases are open cases, so they're big open procedures.
yeah.
I recently started doing minimally invasive work on distal pancreases and some livers, and you've seen some livers get to go home after a partial hepatectomy.
Yeah.
Mhm.
Same day. I've been doing this since 2015. I've been in the west area, so Fairfax and Fair Oaks and Reston Hospital. And I used to have a partner, Dr. Tim Shaver, who retired. That's really the main reason I came here. Then I've known Salame for years. He's been wanting me to come here for years, but we made the decision after we got a new administration here, basically. I used to have an assistant and she's gone.
Aw.
Kayla. Friday was her last day. She's been with me for
Oh.
years. She decided to quit medicine altogether.
Is that your PA?
Yeah,
Oh my gosh.
Kayla. So we're hiring a new one. I interviewed her last week. Her name is Catherine. It seems that all the PAs start with a K for some reason.
Oh yeah.
I interviewed 4 and 4 of them start with a K. So Catherine will
funny.
be here. I'll introduce you guys to her when she starts. She's a nurse practitioner. She's been at Georgetown for 10 years, a nurse in the ICU there.
Oh, I came from Georgetown.
Yeah, Catherine. I don't know her last name. It's difficult.
Yeah, maybe I'll know her when she comes.
Yeah.
That's funny.
So she's a
Small
nurse,
world.
10 years in the ICU. So,
Okay.
and then doing HPB in the ICU.
Oh yeah.
So hopefully she'll be a good fit
Yeah.
here. And mainly, you guys need to know her if you can't catch me if I'm in the OR or something. What else? So this is me in brief. We're trying to get a junior partner by next year to grow this division. We're gonna give it a name and an identity and all that.
Okay.
And we've been really trying to change the way we take care of these big surgeries, to make them as minimally invasive as we can, to make them fast, so the patients, when they come out here, and you've noticed they don't need the ICU. They didn't believe me when I first said that,
Mhm.
but they really don't. And they're generally speaking stable. We try to standardize everything, the blood tests, the EKGs, the X-rays, and all that. So but I want to talk a little bit about the flow of my patients and the reason I order things that I order.
Yeah.
Blood tests are a given. Basically, if we finish a big case, I need a baseline, so by the next day I know what changes. So most of what I do after the surgeries are baselines. I'm not worried about anything. The baseline chest X-ray, baseline EKG, so if something happens on the floor, we know this is new. The X-ray is not for NG tube placement. I've been getting a bunch of calls from here, generally speaking from the young nurses, asking me if the NG tube is in a good position so they can put it to suction. That's not the reason. The chest X-ray is a baseline for the lungs.
Okay.
An NG tube, I place it with my own hand inside of the stomach in surgery, so I know where
Right,
it
it's
is.
surgical
You know where it
place.
is.
Exactly. So that we can, I think
Don't
we
touch
can,
it.
we can just start suction, low continuous suction when the patients get here. We don't need to wait for the
And we're
X-ray.
allowed to check for placement, right?
You can,
Oh, yeah.
for
We
sure.
always do.
Yeah, we always,
Yeah, but I place it myself in a certain
Yeah.
position. There was one time when they removed my NG, that the anesthesia guys after a Whipple.
Oh, no.
So that was a big mistake. I had to come myself put it back because it's tricky then, you know, to place it back. It was my very first Whipple here.
Yeah, I remember.
You
that.
remember?
Anesthesia
I
room,
spent,
but not
so the
that.
guy, I spent 20 minutes with him positioning the NG and all that.
Oh, no.
And after we finished and we did that all, he removed it.
Oh, no.
The very same guy, so, I mean, it went well. Problem is, you're putting an NG tube across an anastomosis. That was freshly made.
Yeah.
That's bad. So, and then I put my patients on the same medications. Very same thing. We have an order set. They all get a PCA. They all get lactated ringers at 100. They all get a bunch of scheduled medications orally. You could probably start those on the floor, not here. But it's okay to give somebody a pill if they have an NG tube. It's okay.
Yeah.
I mean, you can still swallow and it goes down. It's okay to give them sips of anything when they have an NG tube, so the NG tube works better. And that's about it here. Most of my patients have drains. I try to tell the nurses not to basically do anything with the drain. You know, some people try to
Strip it.
strip it. We don't do that. What else? Everything has been standardized, I think, here, and I haven't really gotten many calls at all.
Do you
Other
do
than-
labs,
Labs,
EKGs,
labs,
and
EKGs,
pre-op
just
as
for-
well,
No.
or just here?
Just here.
Just here. So you want the baseline to be after surgery,
Correct.
not whatever they had before. You want to know
Correct.
what afterwards. Okay,
Correct.
that makes more sense.
Anesthesia, sometimes they order labs before a big surgery,
Yeah.
but that's them, not me.
Okay.
My labs are done in the office before surgery, and that's within a couple weeks.
Gotcha.
So I rely on those.
So most of your surgeries are laparoscopic, or, cause you, yeah, I heard you say they're mostly open.
The big ones
The
are
ones I've
the big
seen
ones
are
are
lap.
mostly open. The
Okay.
laparoscopic ones are generally speaking going home. I do a bunch of hand assisted surgeries also, and these
Okay.
they stay here, and they get the same labs and X-ray and EKG afterwards.
Mm-hmm.
The small lap ones, they don't get nothing
Okay.
when they go. Like
Yeah,
yesterday's
that's-
partial liver,
Mm-hmm.
he went home. One of the important things also, I get calls about it. For whatever reason, insurance companies and Medicare, if we touch a liver cell, they want the patient to be an inpatient,
They're behind.
so they can make money. No, it's a deal between them and hospitals. So
Yeah.
anytime we touch the liver, it has to be an inpatient procedure, and they have to stay overnight. They came up with a way around that, which is admit the patient, but then I'll come and check on them and say, oh my God, they look amazing, they can go home. So they, like
So they're
yesterday,
met.
yeah, so yesterday I was in my Whipple and I got a call to the operating room saying, you really want them to stay or are they going home? After I put an order for discharge, and this is mainly the hospital and the care coordinators or whoever that is.
Supervisor.
They want to see that inpatient order so they can bill.
yeah, not
The patients are going
observation,
home.
but meat order.
Yes.
Yeah. Yeah.
Okay.
So then it'll change.
So that's always
So they
an
can
issue.
get
That's
paid.
always an issue that there's no way to put that order.
We
Like
can work around it.
afterwards.
Yeah, it's good knowledge.
It's a
to know.
workaround.
Yeah.
Yeah, I seen it before where they got discharge order and they could not meet order.
Yeah.
And then
we
discharge.
choose.
We get confused.
And then we choose which, like,
Let's
which
see, which
one.
one
That's
is
just
first?
wrong. You know,
Mhm.
whatever
Or
they're
last.
doing is wrong.
Mhm.
It's not ethical, but they do it. I mean, it's
Mhm.
not.
So that's good to
So
know.
what you're saying is that when you first put the orders in, you have to put them in as admission orders.
Correct.
And then
Mhm.
when they come
Then
here,
change.
then they change to outpatient, so we should just go automatically.
And then I
up.
also put a discharge, so I put an admission and a discharge.
Yeah,
But on your screen, it has there's
Right,
two things.
we're like,
Mhm.
what do you
When there's a
want?
discharge order, it's a discharge.
okay,
You know, whether it's an inpatient or not.
Yeah.
gotcha.
Oh, okay.
Mhm.
It's just hard because,
I know.
not everyone practices like you practice, right? Sometimes they'll have admission orders and discharge orders, and then it's pending, it's whether the patient does well here or not.
Yeah.
So then we have to call, and if we need to move, PacuFlow is moving the patient to the next phase of care. So then that's when we need to do something.
Yeah.
Especially if the OR is, spitting them out faster than we can recover.
Yeah.
So that's our only,
I very
That's
rarely
good.
like wait to make a decision.
gotcha, that's good to know.
The decision
Yeah.
is made already.
So if we see 2 orders, both of them, we should assume that they
They're gone.
they should go home,
Yes.
and we should move
And
that
if,
way.
and if you see, small laparoscopic incisions,
Yeah.
that's outpatient.
Right.
I don't keep them.
That's good to
So,
know. We
I
get
just wanna
confused.
clarify, if something is open, then the basic's gonna be chest x-ray, EKGs and lab. If it's laparoscopic, they may not have any of that.
They,
Okay.
and if it's a lab pancreas and they're staying, yes, they do get all these.
Yeah.
Because you
Okay.
want the basic.
Yeah.
for
So
the
take
stay.
it. Anybody's staying
Okay.
gets everything.
Okay.
Anybody's going doesn't get anything.
They won't
Not
be
not
here to
laparoscopic or
compare.
open. So staying, non-staying.
Okay.
I noticed something here that I haven't noticed elsewhere, to be honest with you. People stay longer here in this hospital
The patients,
before
you
going
mean?
home. No, I mean like the outpatient surgeries.
Oh.
In other places, outpatient surgeries are gone in an hour and a half. Here, it's 4 or 5 hours sometimes.
That
I
maybe our
noticed-
outpatient
I noticed that,
staff.
yeah.
Mhm.
Yeah.
Yeah, I mean, and in other places, when I put the discharge order and then I come back a little later after finishing a second, they're gone. Here, they're here longer, 4 or 5 hours at least. I don't know if it's
I wonder
how
why.
things are here. Or,
Coddled.
I mean,
So
it doesn't
when
matter.
you
to me.
round on them, you're saying they're here in the PACU or they're in outpatient?
Oh, anyway, so they're still in the hospital.
When
Okay.
you work in the other hospital, they get a different population, like same population that you get in
Mhm.
here.
The average of how long they stay after an outpatient
Mhm.
procedure is like half.
Yeah, but it's
Oh,
it's the
That's
same
interesting. We
population.
should
Same
Yeah.
population
Same.
of patients,
Yeah.
like age.
I'd be curious
very-
how long
very
we
same.
can track how long they stay over
Because
there.
my patients are
Right.
still mostly coming from there, not
Right,
from
they
not
just
from
come to this
here.
hospital.
So
Yeah.
it's the same
Same
population.
population.
That's
Yeah.
interesting
Yeah.
because I was gonna say in Arlington, it's a different population.
Oh yeah,
I've
but
been working.
I'm not getting
Karen
them.
and I've been working
mostly.
35 years, and
Mhm.
people from Arlington have a very high expectation about
Yeah, they like
taking
to be
care
coddled.
here.
and-
Oh really?
It's much different than people who come from farther.
Mm-hmm.
But people from Arlington, I found that they have different
Mhm.
expectations.
I think I still have maybe 80% of my people are from where I
Yeah.
come from.
Also, it's
Right.
that's
Mhm.
interesting.
Mm-hmm.
Well, I
That's
wonder,
something.
like when I worked at Georgetown, they had 5 discharge spaces. That's it for the whole hospital. And here they have way more over there. So I wonder if they're able that. Yeah. So it was much faster. So I
Yeah.
wonder. I'm
No, I
curious
mean
to
Fairfax,
track.
Fair Oaks, they're big. Reston,
Right.
they're
Right.
big, bigger than
Huge.
here.
Right. But they
Big.
stay
But
less.
they go much quicker.
Okay.
Mhm.
It's good to know.
The other thing is that for phase 2 and anybody going home, if they got a pain pill, they have to keep them for an hour. So I think that's the other reason for buying the time too is, they may be okay with us medicating with IV pain medicine here, and then when they go with phase 2, they start giving them a pain pill.
I don't know. What I know is the anesthesia guys over here have different rules than
Yeah.
elsewhere.
Agreed.
One of the other things I wanted to mention is the Mediports.
Mhm.
The Mediports have to get their X-ray here, not there.
Okay,
Because if they have a pneumothorax, we are gonna
Yeah.
have to put a chest tube here.
it needs to be done and read here.
Exactly.
Before
done
they,
and read before they can go to
Results.
phase 2.
before they eat and drink.
Yeah,
All that
exactly.
stuff.
I mean,
Yeah.
before phase 2.
Yeah, before phase 2, and maybe before we give them anything like that.
Yeah.
I've never put a tube in anyone, but you never know. That's the rule. If it happens
Thank
once,
God. Mm-hmm.
she told me the other day, the charge over there, that it happened to one of the doctors once there,
Oh.
and it was like a shit show.
Yeah.
Good grief.
I knew that's why we did it.
Well, if there was a pneumo over there, they would bump them right back to us.
Yeah.
I
Well,
mean,
what if
there's
it's
no
like
question.
a bad news?
Well, then they
It's-
would
it be-
never
it
have
becomes-
gone
it
over
become-
there.
Exactly. If it
Because
becomes
they would
bad.
have bad SATs, they'd have, you know.
So the
diminished
chest
red
X-ray
cells,
done and
yeah.
read here, and you don't have to call me for. You see no
If it's
pneumothorax, we're
good,
good.
then they're good,
That's
yeah.
it.
Okay,
Yeah. And hopefully you'll never see them.
I hope not.
Yeah.
Yeah.
Maybe this is something we can communicate with X-ray to prioritize, or maybe.
I do it
Yeah,
stat.
it's a stat.
So
Okay.
status.
I do it
It's
stat
okay.
so they can
Because
do
sometimes
it quickly.
when we need the bay, you know, and the patient's completely stable, no signs of, you know, a pneumothorax and.
That's the rule.
No,
Yeah.
I understand what you're saying,
We
I'm
get it,
saying.
yeah.
from
And that's the
a
rule
visual-
because we can't do anything there.
Gotcha.
They would come back. to us.
Basic, exactly. You're gonna have to recreate space for them
Right,
if they have to come back.
we do.
Yeah.
Okay.
Okay, we'll do that.
So what else?
What else?
You do lap, open, metaports,
Bad gallbladders.
bad gallbladders,
There's lots of good bad
cancer.
gallbladders.
It's the other way, between
They
the
stick
spine,
into the
the
spine.
other button, and
This one?
the corner.
You get the one they
Oh,
stick to
scratch,
the
that's what I was
spine.
looking for. I was gonna ask real quick, if say we had, the floors were really busy and we were keeping something like the Whipple here for a long time, like several hours, what are the first things, like on the floor that you would want them to focus on?
Nothing.
Nothing?
I mean, they'll get the pills. They will start getting
Pills.
the pills.
Anything
Or
like
nothing.
ambulation? Do you want them to get up the first day, is that a big thing,
I
or
would
more
love
like,
to,
yeah.
but it doesn't happen.
Okay.
Jesus, on the floor there was one patient, they stayed 3 days before ambulating them. Last
Lord.
year.
Jeez.
3 days. That's a big deal on the floor. They don't do it.
Yeah.
Exercises,
They don't do it.
everything.
But
Yeah.
no, I mean, if you keep them a few more hours, no, that's totally fine to do nothing.
Just
Yeah.
antibiotics.
When they get to the floor, there's
Yeah.
really nothing.
I just was curious.
Okay,
There was,
'cause
Like
we
the,
do
the
board
medications
people
that are
here.
scheduled.
Right, we
Yeah.
board people here
But
before
if
they're.
4A have no rooms,
yeah,
I don't want them to go anywhere else.
just for
So you're 4A,
That's 4A.
Mm-hmm.
okay. That's also
Is
good.
there a reason why?
Because we've trained them. We've spent
Yeah.
so much time training them,
Gotcha.
and that's our floor.
4A.
Mm-hmm.
And a couple times they sent my patients to 6 or
5B.
whatever, 5 or they're not trained.
So the only,
They start asking questions about NG tubes, about
Yeah.
medications. Do you really want them to swallow the pills? Can you check the NG tube on the chest X-ray? It's recreating the wheel.
Yeah.
So, but we've spent so much time
Yeah.
and in services on 4A, they gotten really, really good about what they do. So, and I've talked to the administration, and they all agree that the HPV floor is 4A. Period.
the only, way that a patient would go elsewhere is if they're class 1 tele.
Yes,
So,
Okay,
which
Okay.
is super rare. for
Yeah.
me.
but that would.
We've had one, and we've had an AFib once, I think.
Yeah.
They had to go there,
really,
and it sucked. On that floor, 6 or some cardiac
yeah, 6,
floor.
mhm. And
They
they're
know
like,
nothing about surgery.
Yeah.
Yeah, no,
mm,
And then you usually do albumin and a bolus at night, is
Correct.
that right? Like
At
around
10
10
and
or
11.
11?
Always.
so is that for vascular status and urine output?
No, I
and-
mean they need it. Generally speaking, they,
So
for
by
the
then
for the
they're-
urine output. So generally speaking, they drop their urine output around that time, and the very first day they need it.
Mhm, So
I would only not do it if somebody has a bad heart,
mhm,
but it's become super standard with me.
okay,
And I also, some of the things that they do on the floor, I don't do the bladder scans.
Mm-hmm.
Like, I don't. It doesn't work because my patients have lots of fluids in their belly.
yeah,
They
their
would-
fluid should.
It doesn't exactly. It doesn't. It's wrong. The number is always wrong. So I say no bladder scans, and some of the nurses, they're saying you're putting our licenses on the line. I'm like,
It's
not
not gonna
really.
be correct, interesting.
It's not. It's
Do
wrong.
any of them, come out with Foley's?
Well, so all the big
Sometimes.
surgeries have Foley's.
Will have that
Yeah.
indwelling, so
Yes.
that's okay.
The small ones, like the small surgeries that are going home or that don't get the Foley and are admitted, I don't do bladder scans. Period.
Mhm.
Doesn't work. And it's not, and we've tried, you know. So the machine says, you know, 700, and you put the Foley and there's like 200.
Yeah.
Well, that's, you don't want that.
Yeah, I rely more on the vital signs. I rely more on
The assessment to check the.
the clinical assessment, like the
Yeah.
clinical
Clinical
picture,
assessment.
basically. Is their blood pressure low? That means I have to give them fluids.
Fluid.
Is their heart rate high? I have to give them fluids. They're not peeing if they're not, if they're
Not
comfortable.
making urine then.
If they're comfortable, they're comfortable. It means they need more
Yeah.
fluids. And if they're super uncomfortable and they can't, and that's usually in males, fine, they get the Foley. Clinically, without a bladder scan. They will tell you, I have to go, but I can't.
Right, I need to
Mhm.
pee.
I'm dying. They get the Foley, and it stays, not an in and out.
Okay.
What kind of pills, PO pills, do you normally prescribe for these patients?
Tylenol, gabapentin, tramadol. Scheduled. Scheduled. And they can make them liquid, they can crush them.
Okay.
And not in the NG. They will swallow them. Nothing in the NG whatsoever.
Yeah, we used to flag, stop the suction for like 10 minutes,
Yeah.
15 minutes, and give them.
Works.
But when we had to give
Tramadol.
PO medication,
Mhm.
give them and stop the suction for 10 to 15 minutes,
It works.
and then put it back on.
It works. And this is why I believe that tap locks don't add much to what I do. Because I have a pain pathway. So when I was at Fair Oaks, I did 50 Whipples with a tap lock and 50 Whipples without the tap lock. And there was no difference whatsoever.
They still-
Exparel doesn't work.
Wow.
Simply, it doesn't.
What is the reason?
It doesn't work. I mean, if you give them Tylenol, Neurontin, and
It's
Tramadol, and the
better.
PCA, and it with
Oh,
and
that's right,
without
they
the
have
tap
the
lock,
PCA.
I understand the
Doesn't
tap
matter.
block because sometimes, they don't cover
it's 50-50.
the height. But the Exparel, what is the reason? Because
It doesn't work.
It doesn't work.
You
It's
know,
because of the
people-
liver?
People are not using them. No, they just don't work. These medications, the Exparel, the way they made it, it doesn't. It might work on some patients,
Maybe
but you
for a
look at the
knee.
big picture
Yeah,
Or
not for.
something.
and
But
then
yeah,
do
not
a
for
study.
diffuse
I agree.
There's no
I've seen
difference.
How long does your patient normally stay?
Whipples, 5 days. Big livers, 5 days. Our average Whipple stay is 5.2 days. In the country, it's 11.2 days.
Yeah.
Wow,
Yeah.
that's good.
I mean, we do it quickly, I think, and we minimize anesthesia, try to do it minimally invasive, and stick with the pathway, basically, post-operatively. I have a board on the floor that says what happens every day. So there's patients' expectations also that are met. You tell the patients, your
see
Whipple is
that?
on Monday,
I'll
you're
go
going home
take a
Saturday
picture of
morning,
it.
you're going home Saturday morning.
Good, so then you just go check.
Yeah, exactly. The Foley
Oh, we
comes
like
out on
to
day
see
3, the
that.
NG tube comes out on day 3, the drain
Yeah.
comes out before they
That
go
would be-
home.
Excellent.
Like very, it's automatic. Nobody has
Yeah.
to think
Oh,
about
good,
it.
good.
And generally speaking, maybe 95% of the time we stick with the pathway. Nothing is different. Sometimes
Right.
if their patients are older,
Yeah,
weaker, then we might keep them another day, but that's usually not the case. You tell them so yesterday's Whipple will go home Saturday morning. If you tell them that, and then you prepare their medications before they go home, you prepare their protein shakes, their Gatorade, you set them there at home. So come Saturday morning, they're
Yeah.
ready to go. Yeah. The other cases, distal pancs or livers, 3-4 days. I try to do all my big cases on a Monday so they're gone before the weekend. I currently operate, I have block days, Mondays and Thursdays, all Mondays, all Thursdays. I'm trying to get Wednesday too. I wouldn't do a big case on a Thursday if I don't have to really, if we're not stuck with time, because there's no one here on the weekend. Yeah, if something happens.
So your patient get covered by the resident, or only you, only you?
Ooh, that's a big one to
I am
know.
very OCD and protective.
So no residents.
No
I
residents, no
OCD.
medicine, no nothing,
Mhm.
just me. And now
That's a good
Kayla's gone,
reason
it's
for
just me.
Monday surgery.
Yeah.
You're gonna get one of the cave.
Hopefully soon, they're gonna hire her first as a nurse because it's faster.
And the orientation.
And then they will do the
If needed,
nurse practitioner
the
later
hospital
on.
orientation.
Yeah.
That's good.
Yeah, I so far, I've been able to do it. I've been on call since August 7th.
Wow.
I haven't
Every
taken,
night.
I haven't taken a day off since August
Well,
7th.
Pacquiao won't keep you awake at night.
No, Pacquiao is really good here.
Yeah.
I have no complaints at all. I mean, you haven't heard me, have you? Not even once. No, everything is, you guys know what you're doing, and also everything is automated, kind of.
That's great.
So there's really not much. Yeah.
It's perfect. Go
I hope
A
it
to B
stays like
to
that.
C to D.
We try,
Mm-hmm.
If you make things automated, it becomes simpler on everyone.
Agreed.
Yeah. But I've been super happy here, really.
Good.
Yeah.
It's a good place.
And the OR the OR there is really good, and we have the team, and it's fun, and we've had a holiday party with them, and we brought food last week, also for them, and here same floor is getting there. I think because they change a lot. There's so many new people that come,
Yeah.
especially at nighttime.
Yeah.
It's not stable like here or the OR. The office part, shit show.
Honest. Oh.
Well, because when they hired us, they didn't have a division, they didn't have a budget. They hired us outside of the budget, so I spent 4 months of having no staff, like using maybe Salame's staff for
Oh,
a little
wow.
bit. And now I still don't have staff.
Bunch of staff.
The scheduler started yesterday, and the nurse will start in 2 weeks, and the nurse practitioner in maybe a month. So currently it's me and one medical assistant. His name is Anthony. That's it. So we get the leftover staff to do scheduling and work.
Wow.
Yeah. I'll be in a Whipple like yesterday, and there's a patient calling from home to see whether or not they need to take the nausea medication. There's no one to answer that phone other than me in the OR doing a Whipple.
Yeah.
So it's been difficult, but I think we'll make it.
It's coming along.
Yeah. We'll have, by the time the division's up and running, we'll have 4 staff, myself, and then we will have a junior partner by next year.
Okay.
And then my previous partner, Shaver, is coming back to do some weekends.
Oh, the one who retired? Oh, that's nice.
Yeah, they're gonna bring him back to do 1 weekend a month at least, so I can sleep.
Well, thank you for that.
We
That's
need
nice.
to sleep.
We need to sleep. Yesterday I was dead at 8 p.m. I was dead. I slept on the couch. 8 p.m. I was gone.
I bet.
I mean, these surgeries, the first thing I do when I get home is take an Advil. These surgeries,
Yeah.
they're
I
too
can't
much.
take it.
Yeah. This lady yesterday was a big lady, so it's tougher on my back, on my neck.
Right, get up in there.
Yeah. Well, hopefully when they get us some help, and if you don't have good sleep to fix that, it becomes too much.
Well, I appreciate that you coming and talk to us about
Absolutely.
what you do is make it more clear and
Yeah, we
it
have
make me
good info.
personally make me understand why we do all that when
Yeah,
You know,
absolutely.
and it's, the same test for everyone fit all the tests. And,
But that makes
it's, but
sense,
that makes
baseline.
sense, that makes
For the
sense
floor,
now,
too.
and, it's helpful to know, you know, what,
Absolutely, you
to
guys,
understand what,
you guys can find me
the
anytime I'm
reason,
here,
yeah.
and I have the Epic Messenger, I respond all the time.
Oh, good. So that's a good way to get
Yeah.
you. Right, well, it's good to know no residents, cause they won't be able to answer anything.
Is your office here?
In the TOP.
Salonet,
Oh,
right?
Salonet.
Salonet,
Yeah.
right?
And we're gonna start going to the Fairfax office next month, to the Merrifield office
Oh, okay.
on Fridays.
Oh, nice.
We built a GI center
Mhm.
across the street from Fairfax Hospital.
Mhm, yeah.
And so we're going there, colorectal's going there, Salome David, and GI.
Oh, they are.
Oh, wow.
Yes, so, and we're on the same floor, it's brand new, they just built it.
Is that where the Exxon, I think that's where, that's,
But that's
It's on
BHC,
Pros-
Prosperity.
right,
but
right.
Yeah.
BHC, right?
Yeah, VHC.
Mm-hmm.
Yeah,
Merfield
so,
office.
so we're gonna